afternoon, everybody. I'm Zach London. Thank you so much for coming. So, true or false? It is sometimes ethically acceptable. It is sometimes ethically imperative to treat VIP patients differently than you would treat other patients. True or false? Okay? Well, I use the word ethically, and every time you hear the word ethically in a question, you know the answer already is going to be, well, it's complicated, right? That's always the answer when it comes to ethics. I'm going to tell you 3 stories today, 3 personal stories about things that I have done that pertain to the medical treatment of VIPs. And these are all things that I've done about which I am personally ashamed. Okay? And while I think it's going to be cathartic, hopefully, for me to get these things off my chest, I'm also hoping that this will shed some light on that simple true-false question. And why the answer is that, well, it's complicated. So here's the first one. This is my first shame scenario. I saw my first celebrity patient when I was a neuromuscular fellow. I was very excited. He was just a minor celebrity, but it was very exciting to me. This gentleman had diabetic neuropathy, so I feel, in retrospect, at least my memory serves me, that we treated him exactly the same as we would treat every other patient with diabetic neuropathy, which is that we kind of shrugged and waved our hands and said, there may be a couple of drugs that probably won't help, and then we sent him on his way. So that was all fine. The problem had to do with confidentiality. You see, I can't speak for the Canadians, but we Americans, we kind of love our celebrities. We love meeting them. We love being able to tell people we've met them. I don't know why. Maybe it makes us feel like we have some sort of secondary celebrity status ourselves. And so it was really hard for me to hold my tongue, and I actually managed to do that for about a week, and then I let it slip to my wife. I blurted out to her one day at dinner, guess who I saw in clinic last week? And I told her. And I'm sure she thought much higher of me than she did before. And I felt very cool for about 10 seconds, and then the shame set in because, of course, that was a HIPAA violation. Now, I don't think I told her anything about this person's medical care other than his name, but I still violated his confidentiality, and it should not have happened. Now, here's the first thing I want you to think about. If this person was Joe Smith off the street, that wouldn't have happened, right? So maybe VIPs actually have different needs than other people sometimes. Maybe their confidentiality is at a higher risk of being violated. We're going to come back to that point in a few minutes. Second shame scenario number 2. So around the same time, I started seeing another patient who has stuck with me ever since then. And this is somebody I've had a very good doctor-patient relationship with. A few years into it, he writes me a letter. I get this handwritten letter from him that says, Dear Dr. London, thank you very much for your care. To show my appreciation, I'd like to make a small donation to the Department of Neurology. So this had never happened to me before. I can say that I've had patients bring me brownies. I've had patients bring me corn on the cob. I had one patient who brought me a big bouquet of flowers, but I think she was stalking me. I'd never had anybody bring me money before, and I didn't know what to do. So I called up our development office, and one of our development officers sat down with him and his wife, and it turns out she was really good at her job, the officer, not the wife, because after a couple of meetings, she had turned this small donation into a very large pledge, and an annual pledge, of which I would be the steward. So here I was, junior faculty member, never written a grant before in my life, and suddenly I have access to financial resources that I otherwise would never have had. And I have to tell you, this was great. If you ever get a chance to have a benefactor or an academic sugar daddy, whatever you want to call it, I strongly recommend it. But this was a very new experience for me. And it allowed me to do projects that I never otherwise would have done because I had these financial resources, and it gave me courage to try things. Fast forward a couple of years, and I was going up for promotion. And if you were to look at my CV, it was fairly meager, other than if there was any meat on it at all, it was the stuff that was funded by this donor. And I was promoted. And I got a raise. I think you see where I'm going here. If you connect the dots, it is not hard to say that this patient's donation put money in my pocket. Okay? And this makes me think about campaign finance reform now, because I feel I am now both personally and professionally indebted to this person. And does that change the social dynamic? He's still my patient, right? So do I treat him any differently than I treat any other patient? Do I treat him differently than any other patient? Of course not. Of course not. Except, well, I guess I don't give every patient my email address. And I don't give any other patient my cell phone number. And I think when he emails or calls, I'm probably a little faster to write back than I am with other patients. But that's not really the shameful part. The question is, do I treat him differently? Has my medical care for this individual deviated because of this change in our relationship? I had the opportunity to go back through his record in anticipation for this talk, and I have to be honest, I was really worried about what I was going to find. And I should have been. If you were to go through this record, I think it's safe to say that my care has not deviated from the standard of practice. I have written good notes. I have given him care that is up to the standard of practice. But it is not my standard of practice. You see, I know me, and I know that I'm very conservative with test ordering, for one. And when I look through these records, I see a pattern that is different from that. I think I tended to over-test with this person, much more so than I do with my other patients. So yes, my care did deviate. Why? Why did I do that? I don't know. Maybe I have a greater fear of missing something. So if you don't already think I'm a horrible human being, let me tell you my third shame scenario. This time I'm the VIP. I'm the VIP patient. So I told you this was going to be personal. In my early 30s, I self-diagnosed hypertension. Runs in my family. I knew it was going to happen eventually anyway. And I finally decided maybe for the first time in my life, I ought to actually make an appointment with a primary care physician because I'd never done that since I was a kid. So I got a friend of a friend to make an appointment for me. He worked me in very quickly, worked around my schedule. It was very nice of him to do those things. And he agreed with the diagnosis. He prescribed a thiazide, and I've been taking it ever since then. And my blood pressure has been doing great. Thank you very much for your concern. The issue is, about a year later, it was time for me to get a refill. And I called my pharmacy, and they said, you need to call the clinic. I called the clinic, and they said, our policy is that we do not write refills for people unless they've been seen within the last year. It's a good policy. We have the same policy in our clinic, except that I didn't really want to come in for a visit. So what do you think would happen if I were to email my doctor and say, hey, buddy, it's me. Why don't you go ahead and refill that medication? I don't need the appointment, right? Do you think he's going to say no? And if he does write me that prescription, I'm clearly getting preferential care over his other patients. But am I getting better care or am I getting worse care? I'm certainly not getting the standard of care. All right, so what is a VIP? Very important person. I think in the case of medical care, you could argue that it should be a very influential person. The actual importance doesn't matter. What matters is that it's somebody who influences you to treat them differently. You could say a very intimidating person sometimes. It can be a donor, it can be a celebrity, it can be a doctor, or somebody else of local significance. And I can tell you, you always know when these people are coming to your clinic because their profession makes it into the first sentence of the HPI. This is a 71-year-old retired cardiologist. This is a 54-year-old judge. Why are you including that information in the first sentence, the most important sentence, unless you are announcing to the world that you are going to treat them differently? So a very influential person can also be the dreaded VIP by proxy, right? So the spouse, the relative, the friend of any of the aforementioned people. The regent's granddaughter's pool boy. With an email or a phone call, anybody becomes a VIP, right? And we've all dealt with that. Now, some of you are probably sitting there saying, you know what, that's not me. I'm entirely egalitarian. I treat everybody equally, no matter who they are. I'm going to challenge that. I think there's one category of VIP that every single one of you, every person in this convention center and the one across the street have all treated differently. And it has to do with why we go into neurology. And that is the medically interesting patient. So I've seen the most egalitarian doctors bend over backwards to spend extra time or provide extra resources for people who have something interesting. They certainly do not have greater needs. They're not suffering more than patients with the bread and butter diseases, but taking care of them increases our job satisfaction, so we treat them differently. So is this okay? Well, it's not a problem to want to take good care of your patients. It's not a problem to want to further your career. It is not a problem to want to increase financial resources for your hospital. It's only a problem when these things come into conflict with other goals, like a standard of care for all patients, patient confidentiality, or this concept of distributive justice, which is that we have a limited amount of resources and we should be spreading them equally among all of our patients. That's a conflict of interest. But it's great to be a VIP, right? I mean, shorter wait times, doctors who don't seem rushed when they're talking to you, these are good things. But as you've probably heard, and maybe experienced yourself, VIPs do not always get better care, do they? I gave an example. Sometimes they are over-treated, over-tested. Why? Taking care of VIPs creates this dichotomous thinking. We feel like we have to either be a complete success or a complete failure. There's nothing in between. And that creates unrealistic goals for the physicians. In my neck of the woods, there was a medical service chief who passed away from a cardiac arrest some years ago. And I wasn't there in the room, but the rumor was that he was coded for over 4 hours. Nobody wanted to call it. That is not standard of care. And VIPs may be undertreated, too. There's actually a literature that suggests that we spend less time doing our histories and physicals with them. We're less likely to ask them about sexual history or test them for sexually transmitted diseases. Less likely to diagnose and treat psychiatric illness or to minimize psychiatric illness. So there are plenty of examples of people who have gotten worse care and less care because of their VIP status. Sometimes VIPs are pushy, right? They say, I don't want that test, or I do want that test. Why do we oblige them? We oblige them because we don't want to disrupt these feelings of mutual admiration and respect that we think we have with them. At an extreme, that can lead to physician-assisted substance abuse. Does anyone know who Conrad Murray is? I see a couple nods. All of you are going to remember who he is when I tell you the story. This gentleman, I'm going to take off my shoes to demonstrate here. This gentleman was a Las Vegas-based cardiologist who gave up his practice and got $150,000 a month to take care of just one patient. Michael Jackson, right. So I think we all know that ended. Michael Jackson requested propofol, benzodiazepines, opioids to help him sleep. He had terrible insomnia. How do you say no to the king of pop? Michael Jackson died of respiratory arrest, and Dr. Conrad Murray was convicted of involuntary manslaughter and spent 2 years in prison. There's also this so-called chief syndrome. The chief syndrome is that VIPs feel the need to be treated by the most senior person, or the most senior person feels the need to treat the VIP. Think about who is the most senior person that you work with. Is that the best person to be treating all of your patients? They might not actually have the correct expertise. Or they might not be in the trenches, right? The chair of your department doesn't know their way around the ER, or they don't know their way around the clinic, and whatever benefit their expertise would have is lost. The microcosm of this is when I'm on service and the patient says, you do the lumbar puncture, not the resident. Okay, I haven't done one in 9 years, and they did 3 this week, but if that's what you want, we can do that. So when, if ever, is it justifiable to treat VIPs differently? Well, I alluded to an example at the beginning, and that has to do with confidentiality. In 2007, George Clooney was in a motorcycle accident in Weehawken, New Jersey. He was taken to a local hospital. 27 hospital employees were investigated for peeking at his x-rays and his records and leaking them to the press. Now, that wouldn't have happened to you or me. That would happen to George Clooney. That would not happen to us. So I would argue that just to give him the same benefits of confidentiality that we all have, you should be treating him differently. How do you do that? Well, nobody knows. Some hospitals will put patients like that at the end of the hallway, give them a solo room, post a guard outside the door. Maybe have them have all of their tests portably rather than have them have to go out into the hallway, and then turn those costs over to the VIP. That would be reasonable. But I think we can all agree that VIPs' lives don't matter more than the rest of us. But do their opinions matter more? That's one question I want you to think about. Because failing to provide expedited service for a VIP can have dire consequences for us as individuals or our institutions. They are very influential. They can use that influence to go to the media. Conversely, doing a really good job caring for a VIP, giving them what they feel is preferential treatment, can turn into donations for your hospital, could have positive political implications. So the question is, can those things create value for all patients? Does research money mean better care for everybody? I don't know the answer to that. Actually, I do know the answer. The answer is, well, it's complicated. But I can tell you this. A lot of institutions, a lot of hospitals formally believe that and condone preferential treatment for VIPs for exactly that reason. My institution is one of them, unofficially. I think as individuals, though, we don't always have to be the ones making that decision. The decision we do have to make as individuals is what care to provide for our patients. And I think if I leave you with one message, it's this. If special care is worse care, it is defeating the entire purpose, and we all need to do better at that. I need to do better at that. Thank you very much for your attention.